Welcome to Hand Surgery Resources Podcast. Welcome to Hand Surgery Resources Podcast and Wartenberg's sign. Wartenberg's sign is secondary to chronic ulnar nerve dysfunction and should be distinguished from Wartenberg syndrome, which is a compression neuropathy of the radial dorsal sensory nerve in the distal radial aspect of the forearm and dorsal radial aspect of the hand. Wartenberg's sign is named after Robert Wartenberg, who is described as the Sherlock Holmes of clinical neurology. He first described this sign in 1930. Wartenberg's sign describes the patient's inability to adduct the small finger. This abducted posture is due to the weakness of the third palmar or volar interosseous and is seen in chronic cubital tunnel syndrome or after lacerations of the ulnar nerve. The Wartenberg sign can also be associated with a contracture of the hypothenar muscles. In addition to its association with chronic cubital tunnel syndrome and ulnar nerve lacerations, it can be seen in the beginning stages of multiple sclerosis. The chronically abducted posture of the fifth finger is accentuated by the insertion of the extensor digiti minimi on the ulnar aspect of the base of the proximal phalanx of the little finger. This causes persistent abduction of the little finger due to the unopposed palsy of the third volar interosseous muscle. Patients with this problem describe difficulty getting their hand into a pocket or putting their hand into the coat sleeve. When observing a Wartenberg sign, ask the patient to place the fingers on a flat surface in an extended abducted position. Then ask the patient to abduct the fingers to the midline. If there is a Wartenberg sign present, the patient will be unable to adduct the fifth finger. In this situation, there may be other signs of ulnar nerve dysfunction, such as clawing, weakness of pinch, weakness of the fourth and fifth flexor tendons, and first dorsal interosseous weakness, with a positive Frohman sign. The abduction posture of the fifth finger can also be seen when the cause is not related to an ulnar nerve dysfunction, such as traumatic palmar interosseous muscle rupture, damage to the radiocollateral ligament of the fifth finger MP joint, necrosis or contracture of the hypothenar muscles due to a compression injury, or cerebral palsy, or, as originally mentioned, early stages of multiple sclerosis. In the chronic stage, the patient places the hand on the flat surface. The little finger remains abducted and cannot be brought in line with the ring finger, despite the efforts of the patient to adduct the finger. Therefore, a chronic Wartenberg sign is the patient whose hand, when placed on a flat surface, has an abducted fifth finger, which cannot be adducted despite the best efforts of the patient. Sometimes even the passive motion of the finger by the examiner will not bring the finger in line with the ring finger because of contracture of the hypothenar muscles. The chronic Wartenberg sign can interfere with activities of daily living and general use of the hand. Occasionally, if it is secondary to an ulnar nerve palsy that completely resolves, it may resolve, but this is not the common situation. In chronic cases where there is passive adduction of the finger present and strong extensor digiti minimi tendon function with a muscle grade of 5 out of 5, one can consider correcting the deviation of the finger with a tendon transfer using the extensor digiti minimi. When doing this transfer, the extensor digiti minimi is released from the dorsal ulnar aspect of the fifth finger at the level of the MP joint, dissected free from surrounding tissues back to the level of the extensor retinaculum, redirected on the radial side of the fifth metacarpal, underneath the junctura tendinae between the ring and little finger, and into the insertion tendon of the third volar interosseous, where it is sutured in place. Sometimes it is passed underneath the intermetacarpal ligament to help correct some clawing of the fifth finger as well as the abduction deformity. Prior to tendon transfer, the patient should have full passive motion and may need some hand therapy if there is any contracture of the hypothenar muscles that should be corrected prior to tendon transfer surgery. In addition, patient can use buddy taping to hold the finger in line with the ring finger to facilitate activities of daily living prior to any surgical intervention. One should also be very certain that the diagnosis that is the cause for the Wartenberg sign is known and full treatment options are provided to the patient. One should also continue to keep in mind the difference between Wartenberg sign and Wartenberg syndrome. They both involve nerves, but the Wartenberg sign is a function of a dysfunctional ulnar nerve, and Wartenberg syndrome is a neuritis of the dorsal radial sensory nerve. For more information regarding both of these medical issues, please consult our online free comprehensive text hand surgery source, which can be seen at our website, www.handsurgeryresource.org. Thank you very much for listening.